including my commentary, I was able to review this video in an hour and a half, and the video itself is an hour and a half. Because we watched it at double time, that allowed me time to make my comments, even though we're still within the exact same time frame, precisely an hour and a half of the original video. So I think this worked. I'll try to do this again in the future. Good morning, everybody. Today's the third day of January 2024. And like I said, I believe yesterday on the blog, my plan for this year is to focus more on pain management because I have the intention of refreshing my previous publications on migraine, fibromyalgia, and chronic pain. Actually, the section on chronic pain will be entirely new based on some of my personal experiences over the last couple of years. So, and obviously the science that has developed in that much time. So, consistent with my goal of focusing more on chronic pain this year, I had the idea the other day that I'm going to try to integrate at least one article per day for, let's say, 3 months. And I don't know if that's actually possible because we have some trips planned and some other things obviously will happen in that much time. But let's say 100 articles integrated into the new material before I publish it again. That would be pretty reasonable and certainly worthy of an update. So consistent with that, I'm going to try to look at something every day and integrate that into the book. And it could be an article, like I just said, or in this case, it could be a video. So last night, right before I went to bed, for whatever reason, thanks to the YouTube algorithms, this video came up on my feed, and I didn't watch it because it was too long at that hour, but I did save it obviously for today. And so right now I'm going to go through this video called The Science of Pain Management that was published by Harvard Medical School 5 years ago. So this was 2018 according to the date, I believe, that's on the page. Let me just take a look at it since we're here. So this was March of 2018. So in that case, that makes it almost 6 years ago. But still, 2018, as I mentioned in yesterday's post, 2018 was somewhat important in the sense that one of the most common chronic pain conditions, migraine, received a whole new batch of drugs. Now, how in the world do these drug companies coordinate the release of novel drugs at the same time? So, theoretically, in the so-called free market model, a drug company would innovate in a way that would obviously be different from its competitors. But what we see in the drug companies is they innovate, and then within the same time frame, a bunch of companies have the same product, basically. So the point is, for all of you who love the idea of free market capitalism, is that it's just a sham. Free market capitalism is just a lullaby to make people fall asleep and go for this model of stupidity, basically. But anyway, in 2018, a bunch of drug companies simultaneously invented this same line of drugs, just like they did with the injections for the pandemic. All of a sudden, all of these companies came out with the same platform, targeting the same molecule for the same infection, and we're supposed to believe that that was spontaneous. But anyway, we're going to get back to this topic of pain management. I'm going to go through this, and I'm going to write my notes as I'm going through this, so you'll see the notes that I'm kind of writing to myself. And I expect that, let me say this slightly differently. The way I want to say this is, it's going to be a winning situation. So I'm creating a winning situation here for myself, and hopefully for you as well. And here's the way that I'm structuring this winning situation. Either they're going to say things that are good, so I'm going to call that positive science. So either they will say things that are good and reasonable, and we will collectively get to learn from that, or they're going to say stuff that is so absurdly stupid, I'll call that negative science. They'll say things that are so stupid, and then we'll get to comment on that. And that's, I suppose in some way that's how my books get written, especially on fibromyalgia. Well, on psoriasis as well. It's a combination of what I consider to be positive science. So what does the science actually say? But the other part of it is what I call negative science, and that is just this mountain of bullshit that comes out of these so-called elite universities that's just designed to create medical drones that just pass out pills without any understanding of what's really going on. So through positive science, I get to build competent protocols. Through negative science, that pisses me off. That kind of fuels my anger to get this stuff done and keep working and keep publishing. So either way, this is going to be a winning situation. So I'm going to watch this video. I'll type a few notes and make comments along the way, of course. I'll try to keep it brief because this is an hour and a half long. So I'll probably be sitting here for at least 2 hours doing this. But one way that I can speed that up, I'm going to play this back at 150% speed. So that'll save us some time. If that turns out to be too fast, then obviously I can slow it down. But in order to get through this as fast as possible, I'm going to speed it up, and at least the video playback. And like I said, I'm going to type my notes. I'll try to get through this as fast as possible with maybe not making every comment that I want, but making the comments that I think are really important. And we'll see how this goes. I've never done this exactly in this format, so we'll just see how it goes. But I'm hoping that we get to learn something positive, or if not, then we get to be repulsed by the absolute stupidity of what I expect they're going to represent here. So, but let's just see how it goes. So this is called The Science of Pain Management. Published in this was produced in 2018. So again, I had published Inflammation Mastery in 2016, and I published my first book was an orthopedics review, mostly for chiropractic and naturopathic clinicians and students. So, and I've written other books and articles on pain management. So I think I have some expertise here. And we're going to see how my expertise compares to what they say. And let's see if they say anything worth hearing. But anyway, let's get into it.
Hello, good evening. We have quite a few people still waiting to enter. We have a tremendous turnout tonight, but we'd like to get started. I'm Gina Vild. I'm the Associate Dean for Communications and External Relations at Harvard Medical School, and I am so thrilled. This is my 10th year introducing the Longwood Seminars, and I'm just delighted to see so many familiar faces and some new faces in our Longwood Seminar family. So tonight's topic, the science of pain management, is of tremendous interest to many of you. We choose our topics by having our Longwood Seminar audience vote, and this was definitely a topic for which there was great interest expressed. We're going to talk about the science of pain and how to manage pain, both temporary and chronic. And we're also going to discuss how managing pain has become, unfortunately, a national health crisis. We recognize that this issue touches many lives throughout the country. And so as a result, we're going to provide you with even more information than what you'll garner tonight on opioids and addiction. On a slide that will be on the screen soon, there are 3 additional resources. First, you'll find a wealth of information offered by Harvard Health Publishing. It's content for consumers and clinicians, and I invite you to take a look at this site because you'll find information on addiction and pain, but also information on diet and health and a whole range of topics. Second, last year, we brought together some of the country's leading experts to discuss how education can combat addiction. They included Governor Charlie Baker, who led the governor's opioid addiction working group, and Harvard's own Dr. Bertha Madras, who you will hear from tonight. The program was viewed by tens of thousands of people around the world, and we invite you to view it as well, and that website also is on the screen at hms.harvard.edu/opioids.
So she's just talking about resources, but she talked a little bit about health and nutrition or diet or something like that. I would have zero faith in anything that Harvard puts out, but they are still, a leading voice, not through competence, but through influence. And that's why we're going to pay attention to this right now. She just said that they've had tens of thousands of views.
A third resource was a talk given at Harvard Medical School last year by, again, one of tonight's speakers, Dr. Clifford Wolf. It had an outstanding attendance. It was standing room only, and we invite you to take a look at it. It's the link hms.harvard.edu/talks at 12. I want you to know that in addition to those who are here in the auditorium, we're welcoming thousands of you from throughout the world. So thank you for joining us through the live stream. 2 weeks ago, for the last Longwood Seminar, we had 30,000 people joining us virtually from 82 countries. So to those who are here in person and those who are here through live streaming, welcome. We hope you'll join us for the next 2 Longwood Seminars, Bridging East and West, New Frontiers in Medicine on April 12th, and Weighing the Facts of Obesity will be held on May 9th. Now, just a few brief announcements, and we'll get on with our program. Our speakers are delighted to take your questions tonight, so please write your questions down on the card you were given, and our staff will be walking up and down the aisle, and they will collect those. If you are watching through the live stream, you can write your question in the feed, the Facebook Live comment box, and we will try to feed those questions to our speakers as well. On the screen, you'll see information related to obtaining certificates of completion and professional development points for teachers. Okay, and we also invite you to visit the Longwood Seminars page on the HMS website, where you can find past seminars and watch those from previous years. Many of them are evergreen topics. Now we ask you to please sign.
Well, thank you very much. It's a great pleasure to be here. Gina did the great introduction.
Okay, so this guy, James Rathmel, is a medical doctor. He's going to talk about the science of pain and its management. He's the chair of the Department of Anesthesiology, Perioperative, and Pain Medicine. And he's got an endowment from Leroy Vandam to be professor of anesthesia at Harvard Medical School. Okay, so let's see what this guy's got.
And she made the quintessential mistake, the one that I have over and over throughout my career, of mistaking me for somebody 20 years younger. So thank you. It's a great pleasure to be here. No mic. There we go. Thank you. All right, microphone. So I'm going to talk tonight about the title, The Science of Pain Management. And I put my title a little bit differently, The Science of Pain and Its Management, because the two haven't connected very well yet. We know a whole lot about the science, thanks to some of the people you're going to hear from tonight. And I'm going to tell you a little bit about the management and some of the things we've been through that probably don't work as well as we had first thought they would. I am a chronic pain specialist by training. I've been in this 25 years. I also practice anesthesiology in the operating room as part of my...
So he's a chronic pain specialist for 25 years.
My role is the chair of the department there. So I'm very much involved every day in the management of pain.
And the chair of the department. So bring it on, man.
Surgery and injury, as well as those who go on to have persistent pain that lasts for long periods of time. So like any good teacher, I want to tell you what I'm going to teach you, and then at the end, I'm going to tell you what I just taught you. So we're going to start with what are the things I want to get across. They're really pretty simple. I want you to be able to define what pain is and explain why we have pain. What's its purpose, physiologically? I want you to be able to describe the differences between acute pain, chronic pain, and then this special subset of chronic pain we call neuropathic pain, because it's important to recognize, and the treatments can be very different. I want to talk about how opioid analgesics work to relieve pain, because they do work, and they do have a very prominent role in our armamentarium. But then I'm going to go on and talk about why opioid analgesics are important in the care of acute postoperative pain, but they remain very controversial and are getting more controversial in the treatment of chronic pain, and where that problem comes from. So let's start out with what is pain. So this is the definition, and it's put forward by the International Association for the Study of Pain. It's the biggest international group of clinicians and researchers that have been working at this for decades. And this is the definition they put forward in 1986. Pain is an unpleasant sensory and emotional experience, because there are both components to it, and both are very, very important, that are associated with actual or potential tissue damage or described in terms of such damage. So when you read this definition, it's really important to understand that we as clinicians don't know what you're experiencing. We don't know either the physical experience or the emotional experience or how they're tied together. All we know is what you're describing to us. And so we take it at face value. We come in, we take it at face value, and we move forward from there. It is not measurable. We do not have the magic algometer, although there's lots of work going on in that area. So if you're one of those people who is very innovative, develop an objective measure of pain, and you will do very, very well. So here's the wiring, the physiologic wirings from one of my textbooks early on. So pain, what is it and why do we have it? Now think about this. You put your hand on a stove. You immediately pull away. There's a reflex arc that says, get that out of there. And then you start to feel this burning sensation where you've suffered injury. If you touch that area, now remember, before you put your hand on the stove, if you touch the area, it feels like normal, light touch, right? Doesn't bother you at all. Now you pull it off of the stove, tissue's been injured, and almost immediately you have a sensitization. Now you touch it, light touch hurts, right? It's painful. And Dr. Wolf, early in his career, worked out the anatomic correlates at the level of the spinal cord. We actually increase the gain of a normally light touch, and it's called spinal cord wind-up. That is the sensitization that occurs. And why does it occur? Now think about that. You've just injured yourself. And what the physiology and the rewiring that immediately says, protect that area. Protect it, it's injured, tissue healing has to ensue, and if you keep using it, if you keep re-injuring that same area, it won't heal. And we know that because if in those who are born without the sensation of pain, or in those who lose it, like in damage to the peripheral nervous system that occurs in diabetic neuropathy, they'll injure the same area over and over and over, and they'll end up with open wounds that don't heal and amputations. And that's the important part of this. The other part is, so it comes into the spinal cord level, goes across the midline up to the brain. The important part about the way analgesics work is we can dampen that input. So you see that modulation, that descending limb that comes down to that first order neuron. So I guess I should orient you here. Out in the periphery where the flame is, that's your hand. And then it comes to the spinal cord, which is the central part. There's a very specific area in the spinal cord where that first order neuron comes in and relays the signal up to your brain where you perceive pain. The modulation comes from the central nervous system downward to the spinal cord and says, we can reduce that input so that it's not as severe. We can dampen it down so that you can still function in the face of pretty severe injury. So that's the function of pain, protective. Now what about the different types of pain? So we have acute pain, and acute pain signals tissue injury, just like I told you. It says keep it protected until all of the tissue heals. But at some point, in states where you have recurrent tissue injury, or in those where you've had permanent alterations of the nervous system, you can have pain that persists 3 months, 6 months. There are different definitions, but by and large, beyond 3 to 6 months, we call it chronic pain. And chronic pain can come from a recurrent condition that injures tissue over and over. It can have a waxing and waning pattern, or it can be chronic, persistent, and severe that never lets up. There are many different types of pain, but what underlies it is what is the cause of the tissue injury. Now, there's a special subset of pain that happens when you injure the nervous system, and it's frighteningly common after injury. When you injure the nervous system, sometimes all the tissue injury heals. If you look at the person, if you look at the area that was injured, it looks normal. All of the tissue is healed, but there's persistent pain in that same distribution. We call that neuropathic or abnormal pain associated with nerve function. And there are many different types. You think about tic douloureux, those sudden shooting pains into the face that can occur with stimulation of the trigeminal nerve, just these sudden lancinating pains. Hypersensitivity, even in the area it looks like it's healed. We call those neuropathic pain. And it's important to identify because the treatments are very different for nerve injury pain than for normal pain after illness or injury, that acute pain. All right, so now how is pain treated? Now the science, we diverge from the science a little bit here. So we call pain-relieving drugs analgesics. It's an agent that produces a diminished sensation to pain without loss of consciousness is the actual dictionary definition. And it comes from the Greek algos for pain and an without, analgesia or analgesics. So we're going to talk about a number of different analgesics. Now, first of all, when we approach a person who has any type of pain, remember this is a 20-minute talk, we're not going to get to all different types of pain, but maybe we can entertain specific questions at the end. Pain treatment always begins with identifying the underlying cause. Absolutely critical to identify the underlying cause. And then you can tailor the treatment to the cause of the pain by knowing the expected duration of the pain and what the magnitude of that pain is based on what the patient is telling you, the person that's suffering from the pain is telling you. We use analgesic drugs in a variety of different forms, but it's a really small part of managing patients with pain. I had a person in the Harvard system come up to me at the beginning of this, Carol Martin, came up and told me a little bit about her story and what she's suffering from. And she has focused completely, early in the course of her story, her journey, she was focused on pharmacologic agents and then transitioned to complementary and alternative medicine means studying a wide range of them that can be very, very effective for getting away from pharmacologic treatment. So I think it's important to understand that drugs are a very small part of managing pain overall. All right, but I'm going to focus for a minute on analgesic agents and their uses. Now here's the range of what we have out there. And it begins with acetaminophen. It's a very good analgesic. We don't know exact mechanisms. We have some ideas of where it works in the central nervous system. It's different than the other drugs like ibuprofen, which we lump into a class called nonsteroidal anti-inflammatory drugs. Turns out they're very effective pain relievers for mild to moderate pain, and they really form the cornerstone of management of pain after sports-related injuries, strains and sprains and the like. There's a group of atypical analgesics that work in different ways on different receptors, but have pretty good analgesic effects, and tramadol is one of those you might have heard about. Then there are neuropathic agents that work better for neuropathic pain, those nerve injury pains, than they do.
So I'm going to stop the roll here for just a second, just so I can type out my notes. But you can see how completely non-innovative this guy is already. And I realize he's just getting started. But, and maybe this is why he has his job as being chair, but he's just repeating stuff. I mean, everything he's said so far, you could have gotten out of the Merck manual 30 years ago. And that's probably, I don't know, I don't want to insult him, but maybe that's where he got his education, was just reading the Merck manual. I mean, this is exactly what I didn't want to see. He's just babbling back the same medical, I mean, he's the chair of this department at Harvard Medical School and he's been a professor or expert on this topic for 25 years, he says. And so far he's just repeating, I mean, this is just medical babble. So I'm going to take my notes, and I think while I'm typing out my notes, I'll try to avoid talking, so then I can compress that section of the video so it'll go faster. And you don't have to, watch me type this stuff out, but so far this is really boring. And I appreciate that he probably obligatorily had to go through some review of, basic anatomy or something, but we'll see where he goes with it. He did go through this. This is what I've for 20 years now, because I'm thinking of a presentation I gave back in 2004. This is the Cartesian model, basically. I mean, this is accurate anatomically, but it's still based on the Cartesian idea of sensation and pain and all this kind of stuff. So, should he have presented this image? Yes, it's appropriate to do so, but let's hope he doesn't solely rely on that image. So let me take a quick few notes here, and then we'll keep moving on the video. I am playing it back at double speed because otherwise this would be really painful. Unfortunately, double speed is as fast as I can get it to go. If there was a 3x or a 4x, I'd probably use that as well. But anyway, let me just take a few notes here. So I'm just going to comment very quickly on acetaminophen. He also said, and I think this is well known, that the exact mechanism of acetaminophen is not known, but it's still commonly used. And so the only thing I want to point out about that is that in the world of nutrition and integrative therapeutics, the medical world, the medical profession will often say, oh, well, these interventions don't have a known mechanism, or the science isn't clear, or whatever. And they use that to attack non-drug treatments. But if the same thing applies to a drug treatment, like in this case, they're saying he's repeating what is well known, and that is the exact mechanism of acetaminophen is not known, then somehow that's okay. So if we don't know the mechanism for a drug, then that's okay. But if we don't know the mechanism for a nutrient, then that's a reason to not use the nutrient, according to the medical paradigm. So the other problem that he's presenting is exactly in his method of presenting this. You can tell where he's going to go with this conversation. And he's only one speaker in this panel, apparently. He said it was going to be 20 minutes. But again, these are all old school interventions, and apparently he's going to limit his conversation to these interventions.
That work in different ways on different receptors, but have pretty good analgesic effects, and tramadol is one of those you might have heard about. Then there are neuropathic agents that work better for neuropathic pain, those nerve injury pains, than they do for acute pain, and gabapentin is the best known of those. Then we have an alternative group of drugs that we use in various ways, either topically or by injection. The local anesthetics, they actually work in a completely different way. They block sodium channels, and you get no conduction of the nerve traffic for a good long period of time. We all know that. Lidocaine is the prototypic one now, but the one people know best is by its brand name Novocaine or Procaine. That's used by dentists early on. It's not used much anymore because of sensitivity reactions, and lidocaine is the more common one. It doesn't work for long periods of time, and it completely gets rid of all sensation, so it's very difficult to protect an area that's been anesthetized with a local anesthetic, and that limits their long-term use. And then finally, we're going to talk about opioid analgesics, which is where a lot of this controversy has come up. And the quintessential one, or the prototypic one, is morphine that people know best. All right, now let's talk about opiates and opioids. Opiates are drugs that are derived from the dried latex of the oriental poppy. Now, this is actually a northern poppy from my backyard up in Vermont when I lived there several years ago. The oriental poppy, that's Papaver somniferum, has a very large seed pod. It's set in the middle. When, at the end of the growing season, the petals fall off, you can score that seed pod, and a latex drips out. And it has a number of different compounds in them, morphine being one of them, but a number of different alkaloids that can be extracted. Opium, or tincture of opium, is the raw black tar that dries in the sun. And this has been around a long, long time. Its use dates back thousands of years. Okay? Opiates, the difference between an opiate and an opioid. Opiates come from the poppy plant, and opioids are either synthetically or semi-synthetically derived. And fentanyl is the one in the news. It's an opioid. It's a synthetic opioid that's made in the laboratory that binds to the same receptors. But morphine and fentanyl work in very much the same way. Their potency is incredibly different, so you need a lot less fentanyl to do the same thing as a much larger dose of morphine. So how does it work? Here's the mechanism of action of this drug, and I've showed you that first incoming neuron at the level of the spinal cord, and then there's a blow up here. We know the neurotransmitters and the ion channels where these medications bind, and what they do is bind at the level of the spinal cord and in the brain, and they decrease the magnitude of the incoming traffic. And they're a beautiful system. We have endogenous opioids that are released in the face of danger that bind to the same receptors, and they allow us to function. But it's not like a local anesthetic. You can still feel where the area has been injured. It's just the magnitude of the pain is decreased. So one of the important things to remember with the opioids is you never completely get rid of pain until you reach unconsciousness at very high levels. All right, so what are the side effects of the opioid analgesics of this specific class? So very common side effects. Almost universally, they can produce nausea, vomiting. When you take them for long periods of time, they decrease the motility of the gastrointestinal tract and you get constipation. Itching is very common with it, pruritus, sedation at higher doses. And what we fear most in overdose is respiratory depression. You stop breathing. And I have mouth-to-mouth, a little diagram of mouth-to-mouth. Turns out, we as anesthesiologists often use large doses of these, and respiration stops in the operating room. But we have mechanical ventilation at hand. We can breathe for you during the period of surgery. Opioids are very good in high doses. They're very easy on the cardiovascular system, and they form the cornerstone of very stable anesthetics for things like cardiac surgery. But we have to be there as anesthesiologists to breathe for you. So if you take a very large dose and overdose, and there's not someone there at hand, or you're not there to help breathe for your colleague, then brain death ensues within 5 to 7 minutes, okay? Now, it turns out that sedation comes first, and most people get a level of sedation, but their heart's still pumping. They're not responsive. And that's why naloxone has been so helpful. Naloxone is a pen or a nasal spray. If your heart's still beating and it can circulate, that's actually blocks the receptor where the opioid binds and completely reverses all of the depression. It's really kind of miraculous when you get patients wake up, or a person wakes up immediately. So what's the big controversy about opioid analgesics? They're really good pain medications, particularly in the postoperative period. They work. They work universally. As an anesthesiologist, I could not get through the day helping people with their postoperative pain without these. This is written by Thomas de Quincey at the turn of the 19th century. He was the son of publishers in London. He wrote a 3-volume set called The Confessions of an English Opium Eater. And in the final volume of this set, there's a chapter on, it was mostly about all the wonderful things he experienced in the drug-induced state, all of these wonderful insights into life. But the last chapter is about how opium gives and takes away. It tears at the fabric. It's very, very reinforcing. You come back oftentimes for the euphoric effects, not just the pain-relieving effects. We know that it has this potential, and it falls under addiction. So here are the 3 things we talk about. If you take an an opioid analgesic, morphine, over and over and over, you'll need higher doses to get the same degree of pain relief. That's a normal phenomenon. It's called tolerance, and we know how that occurs. If you stop it all of a sudden, you go through withdrawal, jitters and shaking and high heart rate. That's called physical dependence. Addiction's very different. And it's hard to summarize, but it's really when you lie, cheat, and steal simply to get access to that drug because of its reinforcing effects. And it's a disease of the brain. We know a lot about why it occurs. It's not a bad person that does this. It's a very physical reinforcing effect. What we worry about most, though, as physicians, is when we write this and the person takes that prescription and sells it on the street. Diversion. And that occurs, and we worry about that. Those are the downsides of the opioids. All right, now to finish up, is acute pain different than chronic? Chronic pain, I told you, 3 to 6 months or more. It's extraordinary. This is the Institute of Medicine's report in 2011, and it's 116 million Americans suffer with pain that persists beyond 3 to 6 months, and it can often be debilitating. Opioid analgesics are extremely effective for treating acute postoperative pain. I told you I could not get through the day without them. So it's important that we don't eliminate their availability. We would not be able to treat pain associated with illness, injury, at the end of life, very advanced illnesses, on obstetrics during labor and delivery. They're very important in that. But until recent years, we did not use opioids for treating chronic pain. It was very limited.
Okay. Well, he's saying that within his setting of hospital medicine, he has to use opioids. And that's probably mostly correct. But that's the mistake of the medical model, is they try to extend an acute care model into chronic care. And he apparently isn't going to differentiate between those two things.
Because we don't know about these terrible adverse effects, including the...
Right out of the gate, this guy seems to be positioning his presentation to support and defend the use of opioids. And that would be consistent with what we would expect from Harvard and any so-called elite school. Their job is to defend the interests of the power structure. And so if we have in the United States, and now throughout the world, if we have a population addicted to drugs, then the elite institutions have to defend that. So we have to declare it an emergency, and then we also have to defend its existence at the same time. And that's why things never seem to get better in the United States, especially, which, obviously I spent most of my life in the United States, so I'm more familiar with it. I don't really know the ins and outs of other countries as well. But in the United States, you see this all the time. We're going to declare something an emergency, and then we're going to block any progress from changing the conditions that lead to that emergency. And that's exactly what he's doing right now. And he's doing this from a position of his own experience. And again, it's within his experience of hospital medicine, he's probably correct, because he's treating acute patients, he's treating surgical patients. Yeah, opioids are probably okay in that setting, especially when they're on top of these patients with supervision, etc. But I would hate, and the reason I don't hate, I would hate the experience of thinking that I or someone else is a chronic pain expert, and this is all they know. This is basically all we learned in medical school about pain and medical training when I was working in hospitals. I mean, this is all we did. Everybody got acetaminophen. Everybody got opioids. I mean, this is horrible. He put himself in the position of talking about pain management, so I would hope that his life extends beyond these drugs, but let's see if it does.
Addictive effects of the medications. We thought addiction was very, very uncommon. Turns out it's more common than we at first believed, and some people are more predisposed on exposure to that than others. The science behind this has become more clear in the last several years, and this is the 2015 NIH workshop that centered on prescription drug abuse. The bottom line is there really is no science that suggests that long-term use of chronic opioids, particularly in high doses, is effective for treating any chronic pain condition. That's the stark reality of it. And as you go up in dose, a number of side effects appear with greater and greater frequency, including the risk of things like myocardial infarction and death from overdose as you get to higher doses, even if you're taking them for chronic pain. And that's very frightening and sobering to us. We're going to learn more about what that's done at the national level. So just to finish up, I want to summarize by hoping you can answer each of these questions. What is pain and why do we have pain? Up in dose, a number of side effects.
So let's take a look at this before we move on. This might be an article worth reviewing. He hasn't talked about what he should be talking about. Is acute pain different from chronic pain? That's a stupid question at this level. Not one long-term study related to pain, function, quality of life, opioid abuse, or addiction.
Appear with greater and greater frequency, including the risk of things like myocardial infarction and death from overdose as you get to higher doses, even if you're taking them for chronic pain. And that's very frightening and sobering to us. We're going to learn more about what that's done at the national level. So just to finish up, I want to summarize by hoping you can answer each of these questions. What is pain and why do we have pain? What are the differences between acute, chronic, and neuropathic pain? How do opioid analgesics work to relieve pain? And then why are opioid analgesics important as part of our everyday armamentarium for treating short-term acute pain, but more controversial in treating chronic pain? And I'll leave it at that. Now, next up is Dr. Madras. Did I do it right?
That was really pathetic.
Wonderful.
Wonderful, my ass. That sucked. I mean, it sucks so bad I can barely even articulate its severity of suckiness. That sucked. I mean, this guy's the leading chair of pain management at Harvard Medical School, and that's all he knows? That's all. So he had about 20 minutes, and he used the 20 minutes, and that's all he did? That was horrible.
Thank you very much for coming, and thank you, Gina and Harvard Medical School, for inviting me to this important event.
Okay,
The ancient
hold on.
Greeks, we invoke the Greeks again for a
Sorry, who is this
Pain.
person? The Science of Pain Management. Okay, so this is Bertha Madras, PhD, Professor of Psychobiology, Department of Psychiatry, Harvard Medical School. Opioid crisis. So this whole thing is like centered around defending the use of opioids so far. So why are they calling this the science of pain management? This should basically they should retitle this the justification of opioid overprescription.
Thank you very much for coming, and thank you, Gina and Harvard Medical School, for inviting me to this important event. The ancient Greeks, we invoke the Greeks again for a term called pharmacology.
Up in dose, a number of side effects.
I have to go back to the part where they said this was wonderful. This was stupid.
Wonderful. Thank you very much for coming, and
Wonderful.
thank you, Gina and Harvard Medical School, for inviting me to this important event. The ancient Greeks, we invoke the Greeks again for a term called pharmakon. Pharmakon means a medicine, and it means a poison. And I don't think there's a more apt description for opioids than the word pharmakon, because pharmakon can have remarkable effects in relieving acute pain, and it can also produce addiction and pleasure. And both of these coexist in individuals, whether or not they're feeling pain or not. Pain is the number one self-reported medical reason for using drugs with abuse potential, and pain and pleasure centers in the brain are closely allied and linked. Let's quickly go through, as professors always do, they tell you what they're going to talk about. The opioid crisis, the root causes of it, the commission recommendations, and lessons learned for the future. The United States leads the world in prescription opioids. These are the 30 highest, most prescribing countries in the world, and the United States is number one by far. And on average, it prescribes 5 times more opioids than any other nation, on average. Why is this the case? And let's try to understand it. It also has the dubious distinction of leading the world in opioid overdose deaths. And in the past year, where we have good statistics, and the United States is...
Sorry, I have to go back and get this. Wow. Well, USA leads world in opioid. I don't even think that's right. Lost an I in there somewhere. Opioid doses? Just call it overuse. So this was Humphreys, Lancet, 2017. Wow. Well, I mean, that's completely consistent with, for example, my personal medical training. So I was in medical school from 2006 to 2010. And this is what we learned. This is exactly what we learned. And so no surprise, assuming correctly that my medical education was representative of American medical education, which I believe is completely accurate. No surprise. I mean, if this is what students are taught, then this is how the doctors are going to practice. Wow. That's interesting.
Number one by far. And on average,
So it should get worse. So, I mean, this is no accident. I mean, obviously, in the United States, a certain company directed by a certain family paid a bunch of lobbyists to pay a bunch of politicians, and they, changed the rules and the laws and the emphasis. And, they wanted to make pain like the sixth or the seventh vital sign, which I think was actually probably reasonable. But they did that not to treat pain, but to overprescribe a certain class of opioid drugs, which then led to this national addiction to those same drugs. So again, you see how the education plays into the profiteering, which plays into the politics, which then feeds the profiteering, which then creates a so-called crisis. But in order to perpetuate the crisis, they have to then pay off elite schools like Harvard to defend the use of the same drugs that are causing the crisis.
prescribes 5 times more opioids than any other nation on average. Why is this the case? And let's try to understand it. It also has the dubious distinction of leading the world in opioid overdose deaths. And in the past year, where we have good statistics from the CDC, we've had 64,000 deaths due to all drugs. Prescription opioids, about 10,000, heroin, about 15, and fentanyl is leading the way right now with regard to the fastest rising number of opioid overdose deaths. What are the root causes that gave us this problem? It is so important to remember that the United States has had opioid addiction due to medical reasons in the past. In the 19th century, we had a very severe opioid addiction epidemic in this country because morphine, which was so prominent at the time as one of the most effective medications that physicians had, was given liberally to many people, primarily to women, and then during the Civil and after the Civil War to men who suffered tremendous injuries. But what happened since that time, since around 1910, is that we, for that period of time and up till very recently, physicians were quite reluctant to use and prescribe opioids for chronic pain. We have a case of generational forgetting. We have a problem of quality science. We had very little training with regard to pain management and opioid prescribing. And we had a gigantic disconnect between addiction services and medical services, so that rehabilitation centers were no longer connected with medicine. And as a result, this giant disconnect led medical schools, medical education to largely ignore the issue of addiction, especially with regard to opioids. Generational forgetting was a big problem. For decades, prescription opioids were avoided for chronic pain because of the fear of addiction, because of the fear of overdose, and because of the fear that there was no good evidence for their use in chronic pain. I have excavated the New England Journal of Medicine in Countway Library, which is right down the street here, and there, especially with regard to opioids. Generational forgetting was a big problem. For decades, prescription opioids were avoided for chronic pain because of the fear of addiction, because of the fear of overdose, and because of...
All of this is true. So, at some point before medicine got completely hijacked, these were the legitimate concerns about opioids, just like with opium. Addiction, overdose, and long-term lack of benefit. Worse than that is the fact that these opioids are not only not effective in the long term, but they actually make pain worse. Let's see if they talk about that. Again, I had some suspicion that this entire presentation was going to be nothing more than a whitewashing of the opioid crisis caused by the miseducation of doctors and groups that want to profiteer, and then they want to turn pain into a national crisis, so to speak. And then when they turned pain into a crisis and they equated pain management with opioid prescribing, then of course that created a drug overdose crisis. So let's see if they can get out of their own downward spiral here. I suspect that they maybe won't.
The fear that there was no good evidence for their use in chronic pain. I have excavated the New England Journal of Medicine in Countway Library, which is right down the street here. And there were examples of publications in the 1920s of people trying to figure out how to surmount and overcome an overdose. And in some cases, they used vinegar to make people vomit. And in other cases, they used a tube that they stuck into the intestinal tract to try to extract the drug. So physicians were aware for 200 years that these compounds could give rise to problems. And then something happened. There was a 5-sentence article published in the same New England Journal of Medicine saying that narcotics are not addictive. when given to pain patients. 5 sentences, and it catalyzed a movement to blame a provider for inadequate pain management, a patient movement that began to advocate for opioids, a huge investment by pharmaceutical companies to train physicians, to train patients, to train pain societies that opioids of certain formulations were safe and effective for pain management and not addictive. 20,000 specific events were sponsored by specific pharmaceutical companies to train people that this was a safe form of medication, ignoring 200 years of history in the biomedical journals. And detailers went to doctors' offices to try to convince physicians to use opioids.
So I suspect that she's obviously got better awareness than the previous speaker. But I think what she's talking about here was specifically, she says pain society here. And obviously that would imply more than one organization. But I suspect that she's specifically thinking of the American Pain Society that apparently was paid off by certain drug companies to really push opioid overprescribing. The American Pain Society was later sued almost to the point of bankruptcy for pushing opioid overprescribing that obviously killed a lot of people. So here, she begins to talk about the Veterans Administration adopting pain as the 5th vital sign. That's kind of retarded. So vital signs, of course, are what doctors and nurses have traditionally measured upon evaluating any patient. And depending on what list you look at, you could find either 5 or 7 traditional vital signs, and then they wanted to add pain as number 5. Again, I don't think that's completely unreasonable. They could have done pain and depression. That would have been more reasonable. But it's only reasonable if they're asking the question in order to intervene in a way that's appropriate for the patient, not just looking for any justification to overprescribe opioids. And that's how this was ultimately employed. You didn't see doctors asking about pain so then they could send a patient to a chiropractor or recommend vitamins or B6 or magnesium or vitamin D. No, it was only for opioids. So, they basically turned a decent idea into another drug overprescribing pathway. And we've seen that before.
Veterans Administration responded by adopting a principle of pain as the 5th vital sign, and they mandated pain evaluation and aggressive treatment for pain. 2 years later, the Joint Commission started to consider pain as a 5th vital sign. The other 4 are blood pressure, heart rate, temperature, and the rate at which you breathe. And there was other pressures to satisfy patients' pain, and some of the reimbursements for individual physicians and hospitals were based on whether or not pain was treated aggressively. So there was tremendous pressure on physicians. And then
Right. So she's obviously more aware of what's going on, again, like I already said, than the previous presenter. But you'll notice how this evolves. So over here, in the early history that she reviewed, doctors didn't want to use opioids for obvious reasons of overdose, inefficacy, danger, etc. And then you can see how the language in the journals started to change. CME started to change because these groups like the American Pain Society were getting funded by opioid companies. And so look how that became policy to the point of, anchoring hospital and clinic accreditation on whether or not they were playing this game. So we went from something that was considered against good practice to it becoming mandatory within 11 years. That's pretty impressive.
And there was other pressures to satisfy patients' pain, and some of the reimbursements for individual physicians and hospitals were based on whether or not pain was treated aggressively. So there was tremendous.
But again, it's not about treating pain aggressively. It's about prescribing opioids. They equated pain management with opioid prescribing.
tremendous pressure on physicians. And then every doctor's office and hospital room had a pain assessment tool placed on the walls. The focus turned to pain management and prescribing of opioids. The healthcare community, their feet were on the fire because of inadequate medical education, because there were no real guidelines for using opioids for chronic pain, because of the fifth vital sign, the patient movement. CMS, the Centers for Medicare and Medicaid Services, were actually discouraging the use of non-opioids for treatment. There were other financial incentives, and the FDA was languid during this initial period. And then as prescription opioids began to tighten, there was in some populations a transition to heroin with no contingency to provide substance use disorder treatment, no contingency to provide medications. During this period of time, opioid...
So she's on the ball. So basically what she just said is that doctors, through poor medical training and poor education, which made them dependent on this model, they overprescribed opioids, they got patients addicted, and then when the prescriptions ran out, the patients who were then addicted had nothing more to turn to other than street drugs like heroin.
Prescribing increased by over 300%.